Hi, my name is Jade Seguin. This audio lecture will be on the use of POCUS for shock evaluation in children. It was specifically created for the Montreal Children's PEM CSI course. The objective of this lecture are to help you prepare for the course. I will be recommending some material to review prior to the course. During the audio lecture, I will also briefly review some key points of the knowledge of certain applications, review some anatomy, some pathologic findings, and we will do a brief review of the evidence on this topic. During the PEM CSI course, we will not review the basic of ultrasound physics and knobology. We expect participants to be familiar with ultrasound principles. If you feel like you need a refresher, I highly recommend you listen to this 55-minute podcast created by Mike Stone. It is also important for you to review the Rush exam article, as I will frequently refer to it during this audio lecture, and we will be referring to it throughout the course. After listening to this audio lecture, reading the article, and reviewing the podcast, it's possible that you feel like you need additional material to help consolidate the newly acquired knowledge. I would recommend the 5-minute Sono videos by Jacob Avila. On his website, you can review specific application, and they were created actually for adult emergency provider, but most of the content also applied to children. Shock is a life-threatening condition, which is typically divided into 4 categories: cardiogenic, distributive, obstructive, and hypovolemic. As you know, each type of shock is managed with specific intervention and medical therapy. Therefore, early identification of the type of shock can have a major impact on patient care. In the adult literature, evaluation of the shock patient often includes the Rush examination, which stands for rapid ultrasound in shock and the evaluation of the critically ill. It has 3 main components, including the tank, the pump, and the pipes. The tank refers to the IVC, lungs, and abdomen where fluid can accumulate. The pump is the heart, and the pipes refer to the aorta and DVT. This evaluation differs slightly in children, given aortic aneurysm and DVT are very rare. We actually require an evaluation of the cardiac, lung, IVC, and FAST in order to evaluate children with undifferentiated shock. Let's go through a first case. A 7-year-old boy presents to the emergency department. He was unrestrained passenger in an MVC accident at 70 kilometers an hour. On presentation, his GCS is 15, he has bruising on his chest. His heart rate is 120, his blood pressure is 80/50, he's saturating 96%, and he's breathing at 25. You identified that this child is tachycardic and hypotensive. You suspect hypovolemic shock secondary to bleeding in the context of trauma. As you initiate resuscitation, you decide to perform point-of-care ultrasound to confirm your clinical suspicion. Let's start with the pump. A little bit about knobology. So you can perform this examination using either the curvilinear probe or the phased array probe. The phased array probe is ideal for young children because it will fit better in their small intercostal spaces. For the purpose of this lecture and the PEM CSI course, we will be using the emergency convention where the probe marker is oriented towards the right of the patient. The 4 cardiac views include the subxiphoid, parasternal long, parasternal short, and the apical 4-chamber view. The subxiphoid view is obtained by placing the probe in the transverse plane with the marker oriented towards the right of the patient. Downward pressure is applied and the probe is brought slightly towards the patient's left shoulder. The sonographer will be able to see the liver, RV, and LV deep to it. In this view, the pericardium can also be visualized. Here's a video demonstrating the normal heart in a subxiphoid plane. Please notice the hyperechoic line demonstrating the pericardium in this view. The second view obtained is the parasternal long view, which is obtained by placing the probe in the 2nd or 3rd intercostal space at the left sternal border, with the probe marker oriented to the right shoulder. This will allow for a sagittal view of the LV. In this view, the sonographer will be able to nicely see the LV, the left ventricular outflow tract, the mitral valve, the interventricular septum, and the right ventricle. This video demonstrates a normal heart in the parasternal long view. Please note here the mitral valve leaflet that is touching the septum during diastole. The next view is the parasternal short view, which is obtained by keeping the probe in the second or third intercostal space and rotating the probe 90 degrees towards the right hip. In this view, a cross-section of the LV will be obtained. Assessment of the function should be done at the level of the papillary muscle. Here, over the LV, on top of the LV, you will see a crescentic shape RV. Here is a video of a normal heart in the parasternal short view. The last view is the apical four-chamber view. To obtain this view, the probe is placed at the point of maximal impulse, underneath the nipple of the patient. The probe is in transverse plane and the marker is oriented towards the right of the patient. Positioning the patient in the left lateral decubitus may help. Identification of the four chambers can be seen as depicted on the picture. This is a video showing the four chambers on the apical four-chamber view. Now we will go through some indication and pathologic finding. First, let's start discussing function. The video here demonstrates normal function. You can see the mitral leaflet touching the septum during diastole. The myocardium of the LV also thickens during systole, demonstrating good contractility. In contrast, this video shows poor function. Here you can see that the LV is dilated and does not contract, and the mitral valve is not touching the interventricular septum. This video shows an apical four-chamber view of a patient with poor cardiac function. You can see that the mitral valve here is barely moving during diastole. Here's another example of poor function where the left ventricle is dilated and there is no myocardial thickening during systole. The mitral valve movements are also limited. This view is the parasternal short view where you see the left ventricle poorly contracting. In children, there is less of a focus on measuring the ejection fraction when using bedside ultrasound. The main limitation is that given the small heart size, a few millimeter difference in measurement will have a significant impact on the measurement of the ejection fraction and therefore making it inaccurate. We actually eyeball the function as normal, decrease, or hyperdynamic. It takes practice to become more comfortable at making the correct diagnosis. This video is a video of cardiac standstill, where you see a lack of cardiac activity. Now let's discuss pericardial effusion. This video shows a normal heart. Here you can visualize the hyperechogenic layers of the pericardium. You can see the visceral and parietal layers. In between those two layers, you see a black layer of fluid, which is physiologic pericardial fluid. In this video, you can see that the black fluid in between the visceral and parietal layer of the pericardium is thicker. The effusion is seen in both systole and diastole. This is an important feature that helps distinguish physiologic and pathologic fluid. A pericardial effusion should be seen in both cardiac cycles. The effusion is now seen in the apical four-chamber view and in the parasternal short view. In this last video, you can see that there's a large amount of fluid surrounding the heart. This is a picture of a pericardial tamponade in the right clinical context. In this video, you can see the right ventricle having a diastolic collapse. The heart is also swinging within the large amount of pericardial fluid. The next thing to evaluate is ventricular size. This is a video showing the apical four-chamber view. The ratio of LV to RV should be 2/3, 1/3. If the ventricles are the same size, or if the RV is wider than the LV, it indicates RV overload. In this video, you can see that the right ventricle is a similar size as the left ventricle. Given that the ventricles are similar in size, indicates RV overload. In children, pathologies to consider include pulmonary hypertension, pulmonary embolism, and congenital heart disease. Signs of RV overload can also be assessed by using the parasternal long view and looking at the interventricular septum. If the interventricular septum is straight, forming a D-shaped LV, this is consistent with RV overload. Back to our patient, the 7-year-old boy who was in an MVC. You decide to perform the cardiac examination using POCUS, and this is what you see. In this view, you see a large pericardial effusion. His heart is actually swinging within the fluid. Here you can see that the RV and RA are collapsing during diastole. This indicates a significant pericardial effusion and tamponade in the right clinical context. Here you decide to bolus the patient, call cardiology and cardiac surgery to prep for pericardiocentesis. While everything is organized, you decide to obtain a view of his IVC. Let's talk about obtaining images for IVC. You can perform this examination using the curvilinear probe or the phased array probe. There are many different approaches to start this examination. Here is an example of a short axis view of the IVC. You obtain this view by placing the phased array or curvilinear probe in the mid-epigastric region of a supine patient, with the probe indicator oriented towards the right side of the patient. The first step here is to identify the vertebral body. The vertebral body appears as a hyperechoic structure with a big hypoechoic shadow. Here you can differentiate the IVC from the aorta in the transverse plane easily. The aorta always runs anteriorly to the vertebral body, and the IVC is slightly towards the right of the patient. The aorta is thicker and more pulsatile than the IVC. In previous studies, the IVC to aorta ratio had been used, but it has not shown to predict fluid responsiveness in children. Once the IVC is identified, the probe should be rotated over the IVC in the longitudinal plane. The marker should be oriented towards the patient's head. Visualization of the IVC connected to the right atrium is very important to distinguish it from the aorta. The size of the IVC will vary during the respiratory cycle. The size variation should be measured at 2 to 3 cm below the RA junction. Here's a normal IVC with a respiratory variation of less than 50%. This video demonstrates a flat IVC. Here is a plethoric IVC where the IVC is large, shows no respiratory variation. At the junction of the RA, you can also see a dilated hepatic vein. This indicates high right ventricular pressure. Back to our patient again. Our patient was found to have a plethoric IVC on IVC scanning. You decide to perform a fast evaluation to ensure that there is no intra-abdominal hemorrhage. The fast is done and is normal. Lungs are also evaluated and normal lung sliding is seen on both sides. The patient is sent to OR for pericardiocentesis. Our next patient is a 3-month-old female who presents with failure to thrive, tachypnea, and poor feeding for 1 week. On examination, her heart rate is 140, her blood pressure is 80/50. She is afebrile, saturating 100%, but breathing rapidly at 75 per minute. The story reveals that she had a cold 3 weeks prior and does not seem to get better. She's afebrile and otherwise previously healthy. On examination, she's well perfused, has a heart murmur, and a diffuse wheeze. You start by performing a cardiac point-of-care ultrasound. and this is what you see. You identified that this patient has poor cardiac function. Here what you can see is a dilated left ventricle with an immobile mitral valve. Upon evaluation of her IVC, you see that her IVC is full and plethoric with a dilated hepatic vein. You complete her evaluation by performing a lung point-of-care ultrasound. Lung point-of-care ultrasound can be used for many indications. In children, it can help identify pneumothorax, pulmonary effusion, pulmonary edema, pulmonary contusion, pneumonia, pleural pathology, and others. It is beyond the scope of this lecture and this course to cover all the applications, but we will be happy to answer any questions you may have on the day of the course. The lung point-of-care ultrasound is best performed using a high-frequency transducer. For the complete lung ultrasound, you need a minimum of 6 views. The probe is in longitudinal plane, and the marker is held towards the head of the patient. Views 1 and 2 are done in the mid-clavicular view, starting below the clavicle and going all the way down to the diaphragm. Views 3 and 4 are obtained in the mid-axillary line, starting high up in the axilla, all the way down to the diaphragm. For scanning of the posterior lung fields, the probe is placed in the longitudinal plane between the scapula and the vertebra. The probe is slid down from the top of the back all the way down to the diaphragm. A normal lung ultrasound will identify the following anatomy. Above the pleural line will be subcutaneous tissue. The pleural line will appear as a hyperechoic line in between two ribs, which will be hyperechoic with large hypoechoic shadow behind them. The A line are normal lung artifacts, which are reverberation from the pleura. Here you can see normal lung sliding, where there's slight movement of the pleura. In this video, you can actually appreciate some small comet tails. Comet tails are vertical projection from the pleura that do not reach the bottom of the screen. Here is a picture of a B-line. In adult, a depth of 8 cm is required for a B-line, but in children, given the different sizes of pediatric patients, such a cutoff cannot be used. In general, the vertical projection that comes from the pleura needs to reach the bottom of the screen. The pleural line is usually placed in the upper third of the screen during image acquisition, and the B-line should go all the way to the bottom of the screen. If a vertical projection does not reach all the way down to the bottom of the screen, then it's called a comet tail. In this video, you can see a mix of B-lines that reach all the way down to the bottom of the screen and some smaller comet tail. Here, there's also pleural thickening. Back to our patient with failure to thrive and tachypnea. A lung ultrasound is done and reveals B-lines, like these ones, throughout her chest on all 6 views. This indicates pulmonary edema. The chest X-ray confirms cardiomegaly with increased interstitial marking. Cardiology is consulted, and the patient is diagnosed with heart failure secondary to myocarditis. She started on Lasix and admitted to cardiology. I'm going to say a few words about B-lines, because B-line can be helpful in narrowing the differential diagnosis. Focal B-lines may be seen in pneumonia, pneumonitis, atelectasis, contusions. Diffuse B-line are defined as more than 3 B-lines within one interspace in 2 different lung regions bilaterally. This is also called lung interstitial syndrome. It can be seen in pulmonary edema, interstitial pneumonia, pneumonitis, and diffuse parenchymal lung disease. Now back to the rush examination. Most of the evidence looking at the rush protocol comes from adult studies. Here's a meta-analysis of 5 adult studies looking at the diagnostic accuracy of the rush protocol in undifferentiated shock patient. Overall here, the sensitivity is 87% and the specificity is 98%. This indicates a high accuracy of this test. You can also see the other test characteristic of the rush protocol for each type of shock. Another interesting study was recently published and was an RCT of 6 different hospitals who enrolled 273 adult patients with undifferentiated shock. Patients were randomized to standardized care without ultrasound or a shock POCUS protocol, which included cardiac, lung, abdominal, IVC, and aortic evaluation. In this RCT, there was no difference in survival in both groups at 30 days, no difference in the volume of fluid administered, no difference in inotropic support, CT scanning, or hospital admission rate, suggesting that POCUS does not change outcome. However, we need to remember that these adult literature may not apply to children. There is very little evidence in pediatric looking at the rush protocol in children. However, the evidence is based mostly on case report, which demonstrated an anecdotal benefit of using POCUS to streamline care and improve patient outcome. In a smaller study of PICU children, including 90 kids with septic shock, randomized to conventional PICU care versus serial echocardiogram, there was improved mortality, higher rates, and more rapid shock reversal, shorter ICU stay, less fluid overload, and earlier initiation of inotropic support. More studies are needed in order to prove whether or not rush protocol can impact outcome on children. In conclusion, we can say that once competency is achieved, the rush exam can be performed efficiently in children and can improve diagnostic accuracy, but more evidence is required to demonstrate impact on outcome. I would like to finish by saying that point-of-care ultrasound is only a piece of the diagnostic puzzle. You need to improve image acquisition skills in order to be able to interpret your images and understand their meaning within the clinical context. Should you have any other questions or inquiry before the course or after the course, I'm available to be reached by email or on Twitter. Thank you.